I'm Dr. Sharonne Hayes from Mayo Clinic, and I want to welcome you all here. Pat Mitchell is one of our trustees at Mayo and has graciously offered for us to use this space, but she is tied up. She may show up, but I'm sitting in her chair and going to do a little bit of the honors to start with. We really wanted to have this event as a way to have Mayo convene an event to interact with the media, to talk about medical topics that are important to all of us, hopefully to your readers and to your viewers. We convene this not just with Mayo folks, but in partnership with WomenHeart, the National Coalition for Women with Heart Disease, which represents the 8 million women who are living with heart disease, as well as the 47 million who also are at risk for heart disease, and the National Heart, Lung, Blood Institute, which has been very important in getting the message of heart disease in women and reducing death and disability through its Heart Truth campaign. So we've got partners from all of those groups today. These partnerships are important, and we'd like to try to continue to develop relationships with you and your colleagues going forward. But particularly we chose this topic today because it is the #1 killer of women. And we are going to hear a bit more about that from a video from Dr. Sebelius in just a bit. The day will go forward after that with an initial panel that will cover topics of heart disease predominantly for women who are under 50 or younger women. So women who have heart disease and going through a pregnancy, women who have congenital heart disease and other issues. We'll then take a break and convene for a second panel and talk about some of the heart conditions that affect older women, such as heart failure and coronary artery disease. And then after lunch, we're going to hear from the real heroes of this and the whole reason that we're here, from some of our women heart patients who will tell us some compelling stories about what it's like to be diagnosed with and live with heart disease. I'm pleased to share a message from the HHS Secretary Kathleen Sebelius. And if we can run the video now.
Hi, I'm Secretary of Health and Human Services, Kathleen Sebelius. I'm sorry I'm not with you today, but I want to start by thanking the Mayo Clinic, WomenHeart, and our own National Heart, Lung, and Blood Institute for hosting today's event as part of American Heart Month. I want to thank you all for being here to discuss the #1 health issue facing American women, heart disease. Today, nearly 43 million women, 1/3 of all the women in our country, are living with or at risk for heart disease. By some estimates, that number could rise significantly by 2030. Heart disease is also the leading cause of death among women, claiming more lives than the next 4 causes of death combined. Researchers and scientists know these figures, but it's important that women know them too, because even though women are more likely to die from heart disease than men, they're less likely to receive the recommended care to prevent it, and we need to change that. The Department of Health and Human Services has just launched a campaign called Make the Call, Don't Miss a Beat, to help women spot the symptoms of a heart attack and to call 911. We continue to support the Heart Truth campaign to make women aware of the risk of heart disease and to show them ways to live healthier lives. And the new health reform law, the Affordable Care Act, has given women new tools to prevent and manage their heart conditions. It supports community initiatives to help Americans end unhealthy practices such as tobacco use that can lead to heart disease. And women who join new health insurance plans can now receive free preventive care, like electrocardiograms or EKGs. All of us in government, advocacy organizations, and the media need to work harder to educate women on both the dangers of heart disease and these new tools that are now available to them. Together, we can help American women have healthier hearts and live longer, healthier lives.
Thank you. I also wanted to acknowledge, I did not see her come in, Dr. Regina Benjamin. Is she in the audience? Did she make it? She didn't make it. Well, we'll acknowledge her when she arrives. But I do have, sitting on the couch here, Dr. Sharonne, who is the acting director of the NHLBI. She's overseeing an extensive research portfolio at the NHLBI, which conducts a lot of the research and funds many of the projects that really make a difference in women's lives. Before joining the NHLBI, Dr. Sharonne was a professor of pediatrics and oncology at Case Western Reserve University. She's got a few remarks to make today. Thank you.
Well, good morning. It's lovely to be here, and I want to thank Sharon and the Mayo Clinic for partnering with us on this activity, which is exciting for us. All of the month of February and the Heart Truth campaign is important to NHLBI. As you've heard already, heart disease is the leading cause of death, and it is in women. Over the last 40 years, however, the rates of premature death from heart disease have actually fallen by about 40%. And this is really due to the impact of research, most of which was supported by the NHLBI, on the kinds of things that put people at risk for heart disease and the kinds of things that you can do to manage your risk. This has been very exciting for us to see this happen. On the other hand, we're concerned about the fact that we still have the magnitude of the problem that we have. And we have a number of areas of focus for our research. One of them is health disparities, because the impact of heart disease is not equal in all populations, and we really need to address that. The issues of some of the risks of pregnancy on later development of heart disease. This particularly relates to preeclampsia and to gestational diabetes, which clearly puts people at risk further down the road after the pregnancy is over. And really beginning to be able to personalize cardiovascular care as we learn much more about the genetic risks and components of heart disease. The American Heart Association recently released a study on the spiraling costs of cardiovascular disease. Secretary Sebelius referred obliquely to this. The estimate is that over the next 20 years, between 2010 and 2030, that the annual costs of cardiovascular disease in this country will spiral from about $272 billion to $818 billion, with a significant increase, about 10% increase in the actual rate at which people have heart disease. Just for some context, the annual budget of the National Institute of Health is $32 billion, and the Heart, Lung, and Blood Institute is $3.1 billion. It seems like a lot of money, but when you compare it to $818 billion to treat heart disease, it also seems sort of like a drop in the bucket. The research shows, and there's a lot of evidence that the Heart Truth really helps to get across, that much of this is preventable with better diet and with exercise. In fact, you can decrease your risk of developing heart disease by as much as 82% simply with managing how you live your life on a day-to-day basis. And that is actually one of the things that's most important for us, is getting that message out. Because if we know it, but the people who actually need to make the changes don't know it, then it actually doesn't have the impact that it needs to have. We think it's very important that people understand that research is really not a linear process. You start in the basic science laboratory and you move into the clinic and then you sort of get things out. In fact, the evidence that we get from communities impacts the research that we do. Much of the evidence for the effects of risk factors of heart disease and the impact of better lifestyle choices comes from the Framingham Heart Study, which has been supported by the National Heart, Lung, and Blood Institute since 1948. Using the community of Framingham and families, starting with people who didn't have evidence of heart disease, we're now in the 4th generation of families in Framingham, we identified smoking, high blood cholesterol, hypertension, and family history as major risk factors for the development of heart disease. One of our current emphases now in terms of research is we're really delving into those family history issues as we have more genetics tools that enable us to really personalize, understand what are the components of risk, and this may help us to really personalize the therapy. So inclusive participation of people of all genders, both genders and all ages in research has been incredibly important in terms of what we've been able to learn. Some of the risks are common across groups. Some of them are actually somewhat unique. And we're beginning to learn more about that, particularly about risk factors and manifestations of heart disease in women, which is somewhat different from how it appears in men frequently. So one size doesn't fit all, but many of the kinds of things that we all need to do really do apply to all of us. And it's important to understand, because knowledge is power. Your ability really to have an impact on your risk and your outcome is important, not just for you, but for your mother, your sisters, your daughters, and frankly for all of the men in our lives. One of the key things that's becoming more and more clear is that the risk factors for the development of heart disease start very early. The prenatal origins of adult disease, particularly cardiovascular disease, are becoming increasingly clear. And again, what all of this knowledge does is it gives us a better ability to provide people with guidance to impact that risk. So we want to thank you very much for being here. The NHLBI is excited to participate in this. This is a very important activity for us. The ability to work with powerful partners is one of our essential primary sorts of goals. And again, we want to thank all of you. Thank you very much.
Thank you. I imagine there are a lot of different reasons you chose to be here this morning. Perhaps it's in between shows at Fashion Week. Maybe you were curious about WomenHeart or the NHLBI or about Mayo Clinic, and maybe you were motivated to share some information that we have to share with you today to save women's lives, and all of those are great reasons to be here. Whatever you were expecting, we hope we exceed expectations. We want to give you access to the experts today, so in between sessions and informal and afterwards, we will make ourselves available. We hope we give you a few scoops or at least some ideas for stories so that you can contact individuals later, and all the contact information is in your book. And of course it's Heart Month, so we want to shine a light on this problem. And you've heard, everybody in this room knows that heart disease is the #1 killer of women, but did you know that it's killed more women every year for the past 3 decades? A lot of people don't realize that since 1984, more women than men have died of cardiovascular disease. And we've heard that 47 million are affected by heart disease or at risk for heart disease. But in that same study that Dr. Sharonne was talking about, in 20 years, 40% of women will have some type of cardiovascular disease. And the rate of heart failure and coronary disease will increase by 25%. So that, by most people's definition, is an epidemic. And although we are making strides in research and treatment, this is a growing problem. Women still receive less aggressive care, delayed care, or more likely to be misdiagnosed. And part of that is the lack of research that has been historical in women. And so women have a higher level of death and disability, which is really important. So not only is mortality increased in women for many of these conditions, but the morbidity or the cost of living with heart disease is greater in women. So any condition that kills 500,000 women each year, which is the #1, is an important women's health issue. And in fact, I would argue it is the women's health problem. And if we can do anything is engage you so that women and physicians and the lay public and the media stop focusing entirely on women's health as bikini medicine, you know, breasts and reproductive tract, and move toward what really is the women's health issue, and that's cardiovascular disease, heart disease, and stroke. If we paid half the attention to heart disease as we do to breast cancer, I think we would have a huge impact on women in particular. We're going to, and so as we move to our first panel, I want to introduce our moderator. We are very pleased to have Soledad O'Brien, CNN anchor and special correspondent here, to moderate What Ails the Young Woman's Heart. Ms. O'Brien joined CNN in 2003 as the co-anchor of the network's flagship morning program, American Morning. You've seen her reporting from Hurricane Katrina and the tsunami in Thailand. She's been the producer of several award-winning documentaries, including Almighty Debt, that explored the role of the black church in helping African Americans survive the worst financial crisis since the Great Depression, and Rescue, to look at Haiti's remarkable children during and after the earthquake. So I would like to invite Soledad up to the podium, and she will, no podium. We're a little tight here.
No problem.
Thank you so much
My
for joining
pleasure.
us. And we'll just switch seats. And I just knocked the monitor out.
So welcome, and I thank you all for joining us for a conversation that's really an update on women and cardiovascular disease. We're looking in this particular panel specifically at young women, and we have a stellar panel that's going to who've really focused their research on many facets under this topic. Dr. Heidi Connolly, we're going to bring her up in just a moment. She looks at women with acquired and congenital heart disease. Dr. Elizabeth O'Feely looks at pregnant women with preeclampsia and high blood pressure and diabetes. Dr. Michaela Cook looks at the clinical research and the ability to connect that to healthcare delivery. And Dr. Rakesh Suri will look at minimally invasive techniques in surgery. Now, as you've heard a couple of times already this morning, cardiovascular disease is the leading cause of death in the United States and the world. The term, by the way, we should point out, includes heart disease and stroke and peripheral vascular disease and hypertension and congestive heart failure, and develops over decades. And for that reason, often people think of it as a disease of old or older people. But young people, and young women specifically, are affected and can be at high risk, even though I think women traditionally, we've heard, and obviously for 3 decades, have always been thought of as low risk, maybe not the people who are dying of this disease. In fact, it is, as you've heard, the leading cause of death for women in the United States. To give a little perspective on those large numbers, that is more than the number of people dying from all cancers combined. So in a word, I think it's fair to say that understanding this topic, especially for journalists, is critical. You know, it's one of those stories where you're wondering why people aren't, running through the streets screaming and saying, we're covering this story over here a lot, but the numbers are significantly less. Why is nobody screaming about this other story? So to that end, we have assembled a really tremendous panel, and what I'm going to do is walk you through how it'll work for our panel today. We're going to ask each panelist to come up as I do their introduction and lay out the focus of some of the research that they're doing, and 8 minutes or less has sort of been what I've asked them to do. When that's done, we'll ask a few questions, and then we'll go on to our next panelist. And then when we're done with our entire panel, we'll open it up so you guys can throw out any question that you want for any panelist that you'd like. To that end, then, I will not be doing a lengthy introduction to our panelists. They're all brilliant and incredibly accomplished, and if I were to really do a long intro, it would take forever. But the details are in your pamphlet, so you can look up their bios there. And as a final note to both the journalists and to our doctors, we are on the record. So everything that is said here is usable and usable for attribution. So with no further ado, then, I'll introduce our panel, and I'll ask you to please come up as I read your very brief bio. Heidi Connolly is Vice Chair for Education in the Cardiovascular Division at Mayo Clinic. She is the Director of the Marfan and Thoracic Aortic Clinic at Mayo, has teaching and examining privileges in clinical and translational science at Mayo Graduate School. She's been the Program Director and the Principal Investigator on research grants funded by the National Heart, Lung, and Blood Institute, the National Marfan Foundation, and the National Institutes of Health. It's nice to have you. Thank you very much for being with us. Dr. Elizabeth O'Feely joins us as well. She's a professor of medicine and chief of cardiology at Morehouse School of Medicine, and the director of the Clinical Research Center. She continues to actively evaluate the role of echocardiography in clinical and population-based trials of hypertension, heart failure, with particular relevance to health disparities. It's nice to have you. Thank you for being with us. Michaela Cook is a medical officer in the Clinical Applications and Prevention Branch in the Division of Cardiovascular Sciences, the National Heart, Lung, and Blood Institute. Her research portfolio includes comparative effectiveness research, cardiovascular imaging, racial, ethnic, and gender disparities in cardiovascular disease, and cardiovascular health services and outcomes research in general. It's nice to have you. Thank you for being with us. And Rakesh Suri is an associate professor of surgery and consultant in the Division of Cardiovascular Surgery, both at Mayo Clinic. He is director of the Minimally Invasive Cardiac Surgery Program, chair of the Cardiovascular Surgery Research Committee. He also, along with the Mayo team, participates in cutting-edge research that works to replace the aortic valve using robotic technology and devices that really can do away with the need for traditional surgical stitching. All of that, of course, will cause less trauma to the patients. We're going to have them talk to us about that today. So welcome to all of you. Dr. Connolly, I will ask you to begin. Talk to us a little bit about your work in ways that it can be relevant for people who are journalists and want to write about and understand sort of the big changes that are happening in women's heart health.
Thanks very much. It's a pleasure to be here. Good morning, everybody. I have a particular interest in a number of different things, but perhaps the reason I'm here is because I have special interest and expertise in the management of women who have heart disease during pregnancy. And it's actually a really important topic. It occurs in about 1 to 2% of pregnancies. So if you calculate, that would mean about 40,000 women per year have heart disease during a pregnancy. And it may be something very minor, such as a extra beat or extra beats that don't really require any treatment, or it can be something very serious. For example, a woman who has a serious heart problem that either needs an operation or sometimes it can even cause death during pregnancy, which of course is devastating for everyone. And so I think it's really important to emphasize that this is something that we are aware of, and we need all of you to be aware of as well. There are concerns, there have been concerns in the past that the presence of heart disease in a young woman may preclude the possibility of pregnancy. And in fact, that's not the case. If we know that somebody has heart disease, we want to see them and evaluate them carefully and then determine the risk of a pregnancy to them. And in most cases, we're able to say you are at perhaps increased risk for a heart problem during pregnancy, but pregnancy can be carried out relatively safely with close medical monitoring. On the other hand, there are occasional individuals with heart disease or cardiovascular disease where pregnancy carries such a high risk for maternal death that we would counsel them against pregnancy. And that's really important to identify those individuals and to counsel those women against proceeding with a pregnancy because of the risk of death. Now, our evaluation of individuals would include a regular evaluation like all of you go through in a doctor's office, and then some specialized testing, and we can usually give a pretty good estimate of the risk related to that. I think there are a few individual topics that we should discuss that occur in young women around the time of pregnancy. The first, and I think the most important and most common, is a disorder called peripartum cardiomyopathy. And that's heart dysfunction or heart failure that occurs related to the pregnancy. It's identified usually in the last trimester of pregnancy or in the first 6 months after delivery. And it's not completely understood why this occurs, but it's actually very common and the most common cause of cardiac death in young women. In the U.S., it occurs in about 1 in 2,000 to 4,000 pregnancies, but it's much more common in other countries. For example, Haiti, it occurs in 1 in 300 individuals. So there are particular risk factors that we know about, such as more common in the black population, more common in older mothers, women who have had previous pregnancies, and so on. So really a very important thing to identify for patients to present and for them to get treatment early. The other thing that's important about this disorder, peripartum cardiomyopathy, is that with another pregnancy, if the mother recovers and it goes on to have another pregnancy, she's at increased risk for another episode of this heart failure, and that can be lethal. So we need to be really vigilant about watching women who have had this and then treating them appropriately. Another disorder that occurs frequently during pregnancy, or that we see frequently, is congenital heart disease. And congenital heart disease is heart disease that's present from birth. In the past, doctors have told young women that they shouldn't have pregnancies, and indeed that's largely not the case. Again, we want to see the women before they have a pregnancy to identify which women will get into trouble and to counsel those who shouldn't have a pregnancy against that. But in most cases they can carry out a pregnancy relatively safely. We've looked at that pretty carefully. One important thing about congenital heart disorders and certainly other genetic disorders is that we always want to tell the mother that there's an increased risk of heart disease in their children, and it can range from just a few percent higher than the normal population to as high as 50%, a 50-50 chance with each pregnancy with certain genetic disorders. So that's, I think, really important as well. And finally, one of the hot topics today, of course, is coronary artery disease in women. And in fact, we're seeing that more frequently in women who are pregnant, and that's in part related to aging of or older age of women who are pursuing pregnancy, and also the risk factors that are increasing, all the usual risk factors, smoking, cholesterol, and so on. And so indeed, it's something that we are very aware of, and it's very important because there are a couple of things that make it a very high-risk problem. Women who are pregnant and have coronary symptoms don't present early. They tend to think, gosh, you know, I'm having indigestion or some other problem, and so they present relatively late. And then the healthcare providers don't treat these patients the same way as they aggressively treat women and indeed men who present with heart attacks. And so there's a reluctance to treat pregnant women aggressively because of the concern of what might happen to the baby. And in fact, then you're putting both mother and baby at significant risk. So the risk of dying from a heart attack is much higher during pregnancy than it is if you present at any other time. So I think it's really important to know that heart disease occurs during pregnancy. It doesn't prevent the possibility of pregnancy, but you need to be aware of some of the problems, and then hopefully with appropriate treatment we can get women through pregnancy safely.
Are you finding that young women today are more knowledgeable about their heart health when they're thinking about childbearing? I have to say, and I've knocked out a bunch of kids, it's not a conversation I had with any of my girlfriends when I was thinking about having children at all.
And I think that's a great example. Most women don't think about their heart when they're considering pregnancy. And indeed, sometimes we identify a heart problem because the woman is pregnant, because of the changes that occur during pregnancy, and so it's something that really is underappreciated, and I think really, really needs to be emphasized.
At the same time, you mentioned the reluctance of other physicians to treat pregnant women aggressively, and as you were saying that, I was thinking, yeah, I completely understand that. How do you change that, among your colleagues who would see someone who's pregnant and not necessarily do the math on what's the bigger risk of mortality?
Well, I think something like this is a really important first step. We try to emphasize the importance of heart disease and pregnancy at all of the meetings that we have, and really emphasize that we all need to be the advocates for mothers who are presenting with problems during pregnancy. And so I think, obviously information and education is critically important, but also information for patients and for mothers who are pregnant to remember that if you have chest pain during pregnancy, it might not be indigestion, it might be coronary artery disease. So I think all of those things are really very important.
You said it was interesting to bring people along that a risk of pregnancy isn't as great as they may have thought if there was some kind of heart disease.
Yeah.
But does it matter? Is it correlated, the success of the pregnancy, to whether it's a cesarean? Do you say, listen, anybody who's got some kind of cardiovascular disease, you will be shunted right to cesarean, or is it the reverse? And vaginal delivery is a better delivery?
Yeah, that's a great question, I think, and a really important point, and a common misconception among physicians is that a cesarean delivery is a safer way to deliver a baby. In fact, it's a much, much bigger impact on a woman's body to go through a cesarean section. And certainly if you have heart disease, almost always you'll want to, we prefer to recommend, or we would recommend normal delivery over a cesarean delivery, almost always.
All right. We'll move on to Dr. O'Feely now. Tell us a little bit about the work you're doing.
Actually, I want to just go back to one statistic that I always share with people, so that when I'm speaking to women in the community and physicians, and that is what I call 1 in 1. And people remember that because one woman dies for every minute that we've been sitting here. And that generally gets women...
In the world?
Here in the United States.
In the United States.
Gets women to thinking. Now, when we come to the context of the younger woman, as a preventive cardiologist, what I find is risk factors such as high blood pressure, diabetes are critical. And that cuts across some of the earlier discussion that Dr. Sharonne was talking about health disparities, because high blood pressure and diabetes are accountable for the majority of our healthcare disparities. So when I go back to the issue of high blood pressure, I think it's important to recognize that obviously that's a common condition and the prevalence is growing. We're not exactly sure why, but the most obvious reason is because of the growing prevalence of obesity that we can identify. What happens, of course, is with younger women, most people don't think that young people have high blood pressure, and certainly not younger women. And when they do have high blood pressure, they're not usually in the sphere or practice of a primary care physician. They're usually in the practice of an OB/GYN doctor or a GYN doctor. So part of what a lot of this discussion allow us to do is to highlight the importance of taking care of women sort of across specialties, because their age bracket means they're only in some specialties for care. So a woman would go to a GYN for contraception, for example, and that's the first time most GYNs would check the blood pressure and see, oh, okay, you do have high blood pressure. That's a risk. Being on contraceptives puts a woman at higher risk for developing hypertension if they have a family history. So that's one step of it. Then also recognizing that some women, beyond these traditional risk factors that I mentioned, such as obesity, and that is the issue of African Americans who have the highest risk of high blood pressure. So generally across the population, it's 1 in 4. About 25% of the population has high blood pressure. For the African American community, it's roughly 1 in 3. And in fact, most times when you're in a meeting and it's largely African American patients, just about everyone will know someone in their family who has high blood pressure. So hypertension is pervasive, and we see that commonly among women when they get pregnant. So this is now a situation where a woman already has high blood pressure, goes into the pregnancy with high blood pressure. And that is a problem because pregnancy itself induces a lot of the stressors that we heard about, and then carrying high blood pressure with it creates more problems. The challenge, of course, as a cardiologist, I get these individuals referred to me when they're already pregnant, and everybody's concerned about how do you manage the blood pressure in pregnancy because of the growing fetus. And I think the message here is there are very good treatments available to us now to effectively treat the blood pressure and not do harm to the fetus. And again, that's something that should be done early in the process to avoid the complication. I do want to talk about a particular kind of high blood pressure in pregnancy, which it's been known by various names, sometimes called toxemia of pregnancy, now more commonly known as preeclampsia. The problem with preeclampsia is that actually we are starting to learn a lot more about it, more than we knew before. And one of the striking pieces of information is that it is possible to have a normal outcome of pregnancy even after you're diagnosed with preeclampsia. And this is a condition that's actually determined because, number one, you have high blood pressure where the blood pressure goes dangerously high over a short period of time. And number two, you begin to have damage to other organs. You lose protein in the urine, and some women even develop complications related to convulsions. But the key is when a woman is being followed carefully through her antenatal visits, blood pressure going up can be detected, and most women, of course, are also being checked for protein in the urine, and any level that's above a certain range, the physician immediately knows it's time to monitor this person closely. Unfortunately, though, we still don't know all of the predictors of preeclampsia, so there's a lot of active research going on to understand some of those. We do know, though, now that when a woman has this condition during pregnancy, something happens to the blood vessels where there's a lot of toxins released around the blood vessels. The blood vessels are more likely to constrict in reaction to stress. So some of the tests that we do non-invasively can help us in following these individuals through life. About between 5 and 15 years after pregnancy, some of these women with risks for hypertension and toxemia do develop frank cardiovascular disease, including atherosclerosis and heart attacks, and that's much earlier than you would have expected. So again, this is where close follow-up and understanding the risks and the family history and personal history that individuals have brought through would also contribute to the subsequent management. Perhaps the one area that I think gives all of us concern is that when you look at women between the ages of 35 and 55, where the death rate is going down for all other women, it is from cardiovascular disease, it is actually increasing in this age group. And the CDC has looked at this, and there's been a number of reports about it. And as best we can tell, an important driver of this, in addition to obviously lack of awareness, because people in this age group don't think they're susceptible to heart disease, but the other problem is obesity. And that sort of segues into the issue of what we call gestational diabetes. So because we're now seeing more women, adolescents, teenagers, and young women who are obese, we have detected a significant increase in the prevalence of gestational diabetes. It ranges anywhere from 2 to 12%. And when you look at women from certain ethnic groups such as Native Americans, Hispanic Americans, as well as African Americans, the prevalence of gestational diabetes is at the higher end. And again, these are conditions, because they're unrecognized, could lead to a problem for a young woman. We know, for example, that the presence of gestational diabetes, if undetected, leads to significant problems with fetal wastage, abnormalities of the baby. So again, the focus is recognizing that this can happen, especially if you're looking at a woman who obviously, either through a family history or their own personal history, can be at risk for developing diabetes because of the presence of obesity and other risk factors. Again, there's a good news here, because it used to be when you have diabetes, everybody thinks, oh, you're going to need all these drugs and you're obviously going to be challenged with the pregnancy. Now, there's a large number of research that has confirmed that if you manage these women using a multidisciplinary team of physicians, you can get very good pregnancy outcomes, determine when the baby ought to be born vaginally, and mother and baby really do well. I want to close by just saying, from my standpoint, as a cardiologist who intersects primary care physicians, it is important that we continue to talk to the primary care provider, because they have the big burden of managing all these patients with multiple risk factors. And indeed, we now have, at Morehouse School of Medicine, outreach not only to primary care physicians, but also to OBGYN doctors in the whole area of recognizing that heart disease is a continuum. And these doctors who are managing patients who are young ought to be doing some screening and not waiting for them to get to the age of 40, 45, 50, because then some things have become more established. One of our young researchers at Morehouse School of Medicine recently found that when you take women who have no heart disease history, never been diagnosed, going around their business, they're healthy and fine, and you actually measure the ability of their blood vessel using ultrasound testing to react to stress, a number of them have an abnormal ability to respond to stress. That has been shown to be an early marker of risk for cardiovascular disease. And the interesting thing, to segue into what Dr. Sharonne said, is they also found that putting these women on a DASH diet, which was developed by the NHLBI, not only helped their overall blood pressure, moving it into a more optimal range, but also helped reverse that vascular problem. So that's very exciting.
The young women who you talk to and you see, do they understand, one, I mean, you're clearly saying that there is some personal responsibility in what you can do to manage your own health, that cardiovascular disease has a high correlation between taking care of yourself and not getting it. Right. So do they know that? Do they know, are they aware they're obese?
Yeah. So we've got two problems. One is the awareness rate, it is very low indeed. Women do tend to think, yes, maybe that someone in my family has suffered these problems, there's high blood pressure, there's even stroke and congestive heart failure and kidney problems, but I have some time, and whatever is going on now, I will be able to overcome it later. But unfortunately, again, looking at some of these really large meta-analyses, a pregnant woman, the stress that develops, especially if you have these conditions that I've talked about, does create some sort of a stress test, if you will, so that in the next few years, they're more at risk. And that message is not out because, first of all, we've only come to recognize that within the physician community, and communicating that, of course, is some of what's going on here today.
The good outcomes for preeclampsia, when I was pregnant with my first daughter 11 years ago, preeclampsia was almost death sentence is too strong, but it was terrifying.
Yeah.
It was terrifying, and now it seems like you're saying that there are many good outcomes for preeclampsia. What's changed in the last couple of years?
What's really changed in the last couple of years is recognizing, first of all, picking the patients up early through these testings that I mentioned, but also recognizing that you can control blood pressure effectively, and sometimes women are put to bed rest for periods of time. But almost certainly they do get back out to normal activity. So I think a lot of it has been just better treatment modalities, better ways to diagnose and pick up the condition early on. And then having this multidisciplinary team of physicians manage the patients.
Is that realistic when you're talking about a correlation between obesity, race, gender, ethnicity, poverty, a lack of really being able to get access to health care? A multidisciplinary team sounds fabulous, but not everybody has access to that.
And again, part of it too, Soledad, is all the doctors don't necessarily have to be at the bedside, but it's really more they're involved in the care. So for example, the physicians that I mentioned to you, where we have this relationship with doctors, they know, and certainly Mayo Clinic has exemplified that integrated strategy. They know to connect back and call and say, okay, at what point should this woman be on bed rest? What is the next step? And how much do I need to restrict this woman's activity? So there's more of a comfort level in knowing you have all of this information available, even though the physician is not right there with you.
Great, thank you. Dr. Cook.
Thank you for the opportunity to speak with you here today. The work I wanted to focus on is really around healthcare delivery and how healthcare delivery can impact outcomes for patients and may differ for people of different gender or race and ethnicity. And while we've heard that over the past decades, heart health among Americans has really improved, I think what's key for us to recognize is that all of us haven't shared equally in that improvement. And specifically, we know that heart disease death rates are higher for women than men, and we also know that African Americans die from cardiovascular disease at higher rates than their white counterparts. Specifically, when we look at the occurrence of coronary heart disease, we know that amongst non-Hispanic white population, the rate of heart disease or coronary heart disease is around 6.9%. But when we look at the rates for African American women, that's up at about 7.8%. And for Hispanic women, around 6.6%. So we know that there are differences in both the rates of coronary heart disease as well as death rates from cardiovascular disease by race, ethnicity, and even gender. So I think if we take a step back and we say, how do disparities or differences in the way that healthcare is delivered actually impact the health of a population, and particularly certain races and gender, then we start to question these things, and where in it can we research further to try to understand how to overcome these differences in order to improve outcomes. And specifically, several researchers that have been supported by the National Heart, Lung, and Blood Institute have really tried to focus on these questions to try to understand the contribution of differences in healthcare delivery to outcomes, as well as how to overcome these differences. We specifically have known that over the years we've documented that disparities in healthcare delivery exist. But now it's time to move from just documenting that these disparities exist to really trying to think about how do we solve them? How do we actually eliminate health disparities? And so the research focus is now moving from just documentation to really implementation of solutions and how best to do that. But in order to do that, we have to understand the contributors to possible differences in healthcare delivery. And so really exploring those contributors are the focus of several research studies going on today. Some of those contributors may be related to poverty, as we talked about, or even income and insurance. But what about specifically education and housing and how that may impact the health care that's delivered and patient outcomes? And we also need to understand better patients' access to certain services and cardiovascular procedures as a component of possible contributions to differences in care delivery and outcomes. And we are also interested in that patient-provider interaction and how that actually may impact effective or ineffective communication to really impact the care delivered to an individual, the quality of care that's received, and the outcomes that ultimately are achieved. Hand in hand with this, we recognize that one of the more important things that we need to do is really understand how to translate new scientific discoveries and the research that we're talking about here today into real-world applications for everyone so that we all can quickly be able to adopt the findings that are coming out in current literature and research. We specifically want to know more about how do we implement these findings in every population for every individual as quickly as possible. We want to know about what's the appropriate interaction and interface for generalists and primary care physicians with their specialty care physicians, and this is something that I think we've been all talking about today, and how to optimize that in order to improve outcomes for everyone. We're interested in understanding how variation in the way that procedures are utilized across the country may impact the ability for an individual to access and utilize certain services, and how we can eliminate barriers in access to those services as well as inequity in access. I think that if we take a step back and we say that heart health overall is improving, but we all want to share equally in that improvement, then we have to think about heart disease as being the #1 killer of women, and this includes all women, African American women, Hispanic women, etc. So if we really want to make an impact on the way that heart disease is truly preventable, that we can diagnose it early and treat it when appropriate, then we need to make that step of saying, how do we do this for everyone?
You left us with a giant to-do list. I mean, so what have you seen in initial research that is stunningly great? Where people are saying, okay, we understand there are all these factors. Here's something that looks like it's actually going to change what we know. There is disparity. Got it. We've proven it. We have research on it. How do you get rid of those disparate outcomes?
Well, I think that attacking healthcare disparities are really multifactorial types of problems and approaches that are going to be needed.
Spoken like a true doctor, meaning?
It's a complicated issue, and I think that we're going to have to look at approaches that are going to address all facets of the problem at different levels in order to really try to find solutions. We're going to need to address patient-level issues, provider-level issues, healthcare system-level issues, and in order to do that, it's really going to take a broad integrated approach. However, we have seen some promising lights. Particularly, there's been some recent research that quality improvement programs in hospitals that actually try to get providers to provide evidence-based care and meet quality guidelines regardless of the patient that's present in front of them may have some...
What does that mean? I don't understand. Evidence-based care?
Evidence-based care really refers to the fact that the care that's delivered is based upon the research that we've done in the past and what we know works for people in a certain situation with a certain condition. So it's really following the guidelines for delivery of care.
Regardless of what the patient in front of you looks like.
Regardless of what the patient in front of you looks like. And there's been some suggestion that by doing that, by trying to improve the quality of care delivered for every single person that you see, that you can start to eliminate some of the disparities in healthcare delivery.
You talked a little bit about sort of links to these disparate outcomes, housing, poverty, access, interaction with the provider. I'm curious to know, is there research going on that looks at the gender, the ethnicity, the race of the doctor and the patient? I mean, do black people do better when they have a black doctor? Do women do better when they have a female doctor? Do Latinos do better when their doctor is Latino?
And there is research that actually addresses some of those questions. Some of it is conflicting, but I think that what we call that is concordance of the patient and the provider, where your provider looks like you when you're sitting in the doctor's office. And we found that the communication may be enhanced in those situations. So there seems to be more time spent with an individual when there's concordance present in the clinic visit, and that there seems to be some level of enhanced communication between the two, But when we've tried to link that with outcomes, we haven't necessarily found that same improvement in outcomes in the long term. So we're not sure really the role that concordance plays in terms of really changing the outcomes for patients.
Are you finding that your younger patients are much more knowledgeable and savvy about how to navigate a medical system than your older patients?
Not always.
Really?
And I think that that's something that is important for us to kind of think about in raising awareness, because part of one of the contributors, I would say, that we've actually explored related to healthcare disparities is that there may be cultural differences in the way that an individual will approach their healthcare and the way that they may understand what's happening in terms of the health literacy of a population may differ based upon cultural aspects, education, background, et cetera. And so all of that really comes to play when you're trying to navigate a healthcare system. And so that can really be different dependent on where you're coming from, your age, et cetera. And I think we see the gambit in lower age groups as well as older age groups.
Great. Thank you, Dr. Cook. Dr. Sawyer.
Well, thanks very much, Soledad. So my job today is to tell you a little bit of what's new in heart care, in particular in cardiac surgery. I'm a cardiac surgeon, and I cover the spectrum of adult cardiac surgery. And my particular interest is in valve repair surgery. Valvular heart disease affects women as well as men. But in certain conditions, and some of those that I'll speak to specifically today include mitral valve disease. Mitral valve disease affects 3 to 5% of the population. So if we had 100 people in this room, 3 to 5% of you, some with murmurs, innocuous murmurs, would have mitral valve prolapse and mitral valve regurgitation. And this is an important disease because it leads to heart failure, atrial fibrillation, and sudden death. But
what is that? I'm going to stop you. So what is prolapse and regurgitation? And they sound very, very bad. I never want to hear that from my doctor.
So we always like a valve to close like two cusps coming together, or two leaflets, or a flower closing, in other words. But when prolapse occurs, those two leaflets don't meet each other, and that allows the blood to be pumped backwards through the heart. And you can understand that's not an advantageous condition for a mechanical structure to exist in. So in mitral valve regurgitation, it's very important to get to that diagnosis quickly and monitor that patient, because if patients go to the point of developing symptoms or heart failure, we know that their prognosis is poor, and that could lead to heart failure and death. So valve repair is an important advance in cardiac surgery and in heart disease in general, because it's not offered uniformly throughout the country and throughout the world. So it's very important for these patients to be directed to centers where heart valve repair is offered routinely. And it's also important because women present more frequently with valve prolapse and certain forms of more malignant valve prolapse than do men. And therefore, it should be a condition that's recognized in primary care practice, in cardiology practices, and patients can be directed accordingly. Now, the advantages of valve repair beyond those I've mentioned are as follows. There's excellent durability, so freedom from having the same operation again. There's excellent freedom from infection and clotting. And third, there's freedom from valve-related dependence on blood thinners. And that has special relevance, as I'm sure you can imagine, to the pregnant woman. So that's an important thing that we must remember. Now, Mayo Clinic has been at the forefront of developing and propagating techniques, new ways to repair the mitral valve. And that includes developing innovative ways to do so through smaller incisions. And that affects patients' quality of life and their functional recovery after surgery. Now, this isn't all a happy story. Some patients sit in my office and say that their sisters, mothers, aunts have died even as recently as 25 years ago because of the inability to diagnose, follow, and treat these conditions. So it's very important to recognize that these techniques are not offered uniformly throughout the country. Now, we're not only lucky enough to have that technology available to us today, but we have the ability to, again, perform these without the detrimental breast splitting operation, or the sternal splitting operations that we've all come to associate with heart surgery. Because many people with these symptoms will actively seek to avoid heart surgery with the thought that they can't afford to stop their production at work, leave their families and their care delivery to their relatives. So if we reference the American Heart Association survey of women, two of the most common reasons that women deferred taking on their own heart care or even surgery were as follows. Number one, they felt that they could not abandon their family care responsibilities. and number two, they're responsible for caregiving in their own lives. So minimally invasive valve surgery comes into play.
The system has detected that this conference has reached the duration limit for 3 or fewer participants. And
I guess that's the end of
I've
where I go.
I've gotten
So-
many hard raps in my day, but that was the
So-
voice of God.
So minimally invasive valve surgery, what does that mean, Soledad? So with the advances in imaging, such as you see on the Super Bowl or high definition television, we're able to utilize that same technology to see inside the patient's chest. And you may have heard words like the robot or the Da Vinci robot. Well, that merely allows the surgeon to have the same wristed movements of a technically specific procedure like mitral valve repair, but performed instead of a hole the size of a hand to get into the chest, it's actually performed through holes the size of a fingertip. So what's called port access surgery. And we're able to perform that routinely, and we do every day at Mayo Clinic and other centers, a few centers around the nation, through small port access incisions. And what are the advantages of that? Well, they're important advantages, and it's actually very, very it's very rewarding as a physician to see these patients benefit in these ways. Patients are able to come out from surgery with the breathing tube out of their throats. They're able to transition to ward-based care that same night with their family members by their bedside. In fact, I've even had female cardiologists wake up on the table and listen to their heart valves right after the operation, which is a funny thing to see. Number three, they have less blood transfusions. In other words, they have less blood loss and less need for blood transfusions. They're able to leave hospital pretty routinely nowadays within 3 days after surgery. I've had people go back to work as early as 6 days after surgery, so resumption of normal employment-based activities. And importantly, again, particularly in this forum, people are able to rejoin their families' lives as soon as they possibly can. So they're no longer on the sidelines after seeking life-saving therapy. They're able to rejoin their families and productive lives. So the important message I'm here to deliver today is it's no longer time to avoid life-saving therapies. There's innovative ways for women, and in fact all of us, to take care of our hearts, and we just have to seek the appropriate modalities of care.
How do the young women who come to you with prolapse, how do they present? Are they very sick by then? Do they not even know that they have a problem sometimes?
Well, that's the catch-22 here, is that people look like you, Soledad. They look well, and that's when they should have surgery, is before they have symptoms. Because if a patient comes to us in heart failure or atrial fibrillation, or God forbid having a sudden death episode, that it's oftentimes too late.
I would imagine that young women, and I'm so not young, but I would imagine that having their heart health checked, as we've discussed, is not on the top of the things to do. How do you convince someone who says, I'm feeling well, I'm looking well, I don't think I have a problem, that I should go get my heart checked?
Right. Well, the speakers before me this morning have brought up very important points, and that include the assessment of valvular heart disease is part of a normal, routine physical checkup. The only sophisticated piece of equipment necessary to make this diagnosis is often a stethoscope. And therefore, if we get that message out to people that they need to participate in normal primary care, normal health care surveillance, then these diseases are detected, leading to an echocardiogram by experts such as Dr. Connolly, and we work in very close association with our cardiology colleagues to take the ball at that point once the diagnosis is made that severe mitral regurgitation exists, and then indications are to proceed to surgery at that stage oftentimes.
Do women and young women have a different perspective on minimally invasive techniques than, say, your average 65-year-old guy who's sitting in your office?
Well, that's a very interesting question. And you know, the 90-year-olds on a California beach are as anxious to avail themselves of this opportunity as the former group you spoke of. So really, this is a technique with special applicability and advantage to the subgroup we're speaking of today, but in reality, all patients benefit from these minimally invasive approaches.
My guess is the 90-year-old is not saying, well, I'm not sure I can do this because I've got to take care of my family, and I've got to, and I know that list you were ticking off is very real.
Yes.
You may not get your checkup, but you're going to make sure your husband does. You may not take care of yourself because you've got children you're taking to their medical appointments.
That's right. And again, the American Heart Survey of Women was a very important insight into that. Once again, it did point out that the two biggest reasons are family commitments and caregiving duties. And therefore, if we're able to get women back to their perceived roles of importance as quickly as possible, then that's a true advantage and will allow patients to avail themselves of these life-saving therapies.
Great. Dr. Surya, thank you very much.
Thank
I'm
you.
going to open this up now. We have 20 minutes or so for questions from our audience, and you can pick the person you'd like to hear from, or you can throw out a question in general, and we'll have all of our doctors take a look. If you would do me a favor and stand up and introduce yourself, that would help.
And then when you were talking about mitral valve disease, I thought like a long time ago I remember hearing that a lot of women have mitral valve. So what's the distinguishing factor with Hernia's surgery in 2000?
With regard to the presentation, I think it varies, just like patients in general. Not all patients will present the same way with particular problems. And so although some of the women with heart disease present just the same as, some of the women who are pregnant who have heart disease present just the same as women who are not pregnant or men who have the same heart problem. Everybody's a little bit different. So they may have very different presentations. And as I referred to, with regard to coronary artery disease in particular, a lot of times women will present very late because they feel themselves that this is just more indigestion or a little bit worse chest pain than they've had before. They've been having chest pain on and off for many weeks. So it is variable, and you just have to be aware of the different presentations, I think. I don't know if
I
you have
just want to add that part of also the discussion with women is some women think, okay, I've gained weight and then I'm pregnant and that's why I'm really feeling, short of breath. And the message we give out is just because you're pregnant and gain weight does not mean you're short of breath. So shortness of breath in and of itself is not consistent with just normal pregnancy. So they need to seek help and at least get evaluated if they have not been in antenatal care, but certainly also discuss that with the OBGYN because it may be time to refer. And some of the physical exam findings that we talked about, such as heart murmurs, may become louder in pregnancy. And again, the cardiologist would need to differentiate whether this represents a true worsening, say for an example, a previously mild heart murmur, and something that would require extra attention. And again, that evaluation would lead you to the next step.
So as regards the timing of surgery, at Mayo Clinic, I'm very happy to be part of a team that studies this issue. And in essence, it's a complex one, and it involves the analysis of echocardiographic and clinical criteria. What does that mean? The bottom line to a physician and a woman is as follows. If a woman presents with a heart murmur, she needs an echocardiogram and a thorough assessment by a cardiovascular specialist. Once certain criteria are met on echocardiography and symptoms, then that patient is referred on to surgery. But merely determining that at the patient level or even the primary care level is very complicated and not recommended. So bottom line is an echocardiogram and a visit with a cardiovascular specialist, i.e. a valve cardiologist, is a key first step.
Another question, right here.
Hi, I'm Charlene Gianetti from the website Women Around Town. Dr. Surya, I wanted to ask you to elaborate a little bit when you say that valve repair is not universally available around the country and around the world. I mean, I tend to think of valve repair as being such a common operation that you could get it anywhere. So how has that happened? What's being done to improve the services to people who don't have access to it right now?
Well, that's a very good question. So let me give you a little bit of a picture of the landscape. The Society of Thoracic Surgeons maintains a database that tracks on a yearly basis what the procedures and the nature of the procedures are that are performed surgically around the nation. To the best of our estimation, the last published iteration of that detailed that only half of repairable valves were repaired around the U.S. Now, there's various factors that contribute to that, but to summarize it, valve repair is a very judgment-based, highly technical operation, and it's performed in centers of excellence, not only where the surgical expertise exists, but where a true cardiovascular team exists. And as I've mentioned, the importance of the cardiologist, the echocardiographers, the surgical team, and post-operative care and surveillance is all a part of that equation for success. And those teams exist at several places around the country, including Mayo Clinic, and that's why we've evolved to develop these centers of excellence for valve repair. The guidelines themselves have that built into them. They say that patients should be referred for surgery when they're asymptomatic, even with normal ejection fractions or normal pumping function of the heart, if they're sent to a center where the chance of valve repair is greater than 90%. And I'm currently on the guidelines committee to develop robotic criteria, which are further more specialized than that, to detail who should be performing these minimally invasive mitral valve repairs. In other words, there'll be a criteria, a minimum criteria or a minimum volume of valve repair surgery that a surgeon must fulfill, and then a certain team-based expertise in minimally invasive surgery to further offer these procedures from there. But in the process of that, when we stand back and look at the whole landscape of American healthcare, that unfortunately doesn't uniformly exist in all healthcare centers throughout the country.
Another question. Go ahead.
Hi, I'm Melissa Walton. Shirley, I'm a cardiologist and I work at theheart.org. And thank you very much. I encountered a patient a couple of years ago that was in her 3rd trimester of pregnancy, and she had unstable angina. So I'm an angiographer, but I don't have a high-risk neonatal specialist, so I wanted to transfer her out for a cath, and it took me an hour and a half, 3 centers. I was turned down. You know, I wanted to ask you to address the specifics of shielding the fetus against radiation exposure and anticoagulant selection and stent selection, timing of discontinuance for delivery, et cetera. Because how can you make us more comfortable to take care of those patients?
Well, I think that's a really common problem, and we get a lot of phone calls about patients like that, and there's incredible anxiety among physicians to care for women who are pregnant. And some of it is justified, but delay in treatment is not acceptable. And so with regard to a patient who either has unstable angina or is in the process of having a heart attack, I think the critical thing is to get blood to the heart as fast as possible. And most commonly that will be in the catheterization laboratory, and it can be done safely and effectively in a very fast manner. Of course, if a woman is pregnant, we would shield the fetus, but the amount of radiation exposure is really very small to the fetus during a procedure like that. So some of the technical details I think we can talk about maybe later, but we would usually recommend that the type of stent that's used not be the drug-eluting stent, the newer type of stent that's used, because of the medications that are required for that type of stent placement have not been really studied during pregnancy. And so we'd usually use either a balloon procedure or a bare metal stent, and then give appropriate blood thinning medications such as heparin and all the other medications as well. So, but the most important thing I think to emphasize is to treat the patient first. That the baby won't survive if the mother doesn't survive. And so that's really, I think, the most important thing to emphasize. Sounds like that's what you were struggling with. Yeah.
She got a bare metal stent. She did very well, but we were lucky that we were 6 weeks away from delivery.
Right.
So we had plenty of time for that to materialize.
Right. Yeah. And I think you bring up another important point, and that is if you don't know what, if a healthcare provider doesn't know what to do, they should call for help. That's, I think, another really important thing.
Another question. How do you best get the word out to these young women who clearly, I'm sort of stunned when you say that women are not necessarily more knowledgeable in this day and age with 30 years of knowing that heart care is lacking for women, especially women of color. What do you do?
I actually think that awareness campaigns are one way in which we're trying to really get a message out. And it's something like the Heart Truth campaign, the Women's Heart involvement, and these types of event, Mayo Clinic's involvement, are really to raise awareness, to say these are things that we really think are important for younger women to pay attention to take their personal risks seriously. Because I think that what we're recognizing is that women kind of nod and say, yes, I know that, but it's not a serious acceptance of the fact that there may be a risk for development of problems down the line. There's also engagement, as we've heard across the panel today, of the primary care physician and the OBGYN, if that's the primary care, in assessment of personal risk, as well as in the follow-up of risk after certain risk factors have been identified. And so I think it's that patient-provider engagement about trying to understand what this means for you and to ask questions about how do I navigate a healthcare system now that I know these things about myself, that I think young women have to start engaging in as well. Older women, I think, automatically take that upon themselves once they've come into the healthcare system, recognizing that as you get older, you naturally have kind of the risk of developing other types of disease, but younger women aren't yet there. And I think it's raising that awareness to do that.
I would say that just looking back to what's happened over the years and guidelines are put forth, and a lot of the times these guidelines just sit on shelves and it just is not, there's no practical way to translate it to either the practicing physician or the patient who's the ultimate consumer of health. So I think a number of the discussions, and certainly around some of the healthcare reform strategies, is actually look to not just professional societies to not just develop guidelines, but embed in those guidelines some actionable steps that include what is the message for the primary care physician, how to implement these. And I think some of those how-to messages, when you take the case of the young woman, targeting the GYN practitioner who is likely to encounter a young woman at between the ages of 18 and 35. And a number of these collaborations with cardiologists are now going on to not only drive the awareness, but also to engage the young patient in understanding that risk is a possibility. But finally, I think there's nothing that gets a woman's attention as actually showing some of the data with regard to screening. And that's what we found with, some of these. So you tell a woman your cholesterol is 250 or 200, and so I know I'm eating bad and I'll do something different about it. But if you actually drill down and say, well, guess what? Your blood vessels are now reacting almost like a 55-year-olds or 60-year-olds, that gets a little bit different level of attention.
Another question right here.
Could I follow up, if you would? I'm Howard Green with the Heart.org and Medscape, and also with WomenHeart. Dr. Cook, what you were saying about to raise awareness, one of the things that I find kind of not that surprising is to put a face to cardiovascular disease in women seems to be a way to leverage some of the guidelines and some of the data. Barbara Walters, as awful as it is what she's going through, she is now the face, if you will, of maybe valvular disease. And so is that part of the strategy behind what cardiologists are doing to try and say this can happen to anyone, including this well-known woman, and how you leverage that?
I wouldn't necessarily say, but I would say that seeing patients individually, I've personally referred them to women's groups as well, and particularly to WomenHeart, to try to understand that there are other women in their age group, especially younger women, that are having these problems, and they have actually taken it upon themselves to be the banner for understanding that women's heart disease affects women just like me. And we have several patients here today, and I'd like to thank them for doing that because I think they've been very effective in doing that. So I wouldn't necessarily say that it has to be the person of prominence, but everyday women can do this in their own communities, in their own churches, to say, I know that for young women, 1 in 19 have heart disease, and I'm one of them, and I can look just like you. And so I think it's an activism that can happen at every level. So I wouldn't necessarily focus it on the high profile, but say that all of us have a role to play in this.
I was involved, just last week, the First Lady of Morehouse School of Medicine, she did something interesting. She set up what she was calling women with heart, as a way to create awareness. And she basically got survivors, and they were all different women. And what really struck me was they were all different ages. So there was a woman who is now in her 40s, but she had her valve problem when she was in her 20s, and was totally, she told the story in her own words about how she went through different assessments, was in the hospital emergency room several times. She happened to have endocarditis, but it was unrecognized. I mean, by listening, even though I'm a physician, just hearing this woman's story just brought home where all of the missteps that can happen within the healthcare system. And she was being given pain medicines and fever-reducing medicines. She finally said, well, I'm just not going to take anything. Was only admitted when her fever hit 104. So to me, I think those kinds of stories are very important to allow patients to see, okay, you know, that fever that I have, maybe someone ought to take a look and see, is there anything related to my heart? I know you want to raise awareness, you don't want to create panic, and so that's why the whole story and sort of just wrapping it around and making sure people understand what the end game is and the opportunity to reduce that risk. I was actually quite impressed with that type of an outreach.
Another question, go ahead.
My name is Amparo Villablanca. I'm a cardiologist and direct the Women's Cardiovascular Medicine Program at UC Davis. And I wanted to just briefly make a comment about one of the important barriers to women seeking preventive care, which is their family care responsibilities for both their primary family and perhaps extended family. And I think there's a very simple but effective message that you as members of the media can help us get out, and that is that a healthy woman equals a healthy family. You have to have a healthy woman in order to have a healthy family, because women are the primary caretakers for most families. And I think if we could help get that out to women, it might help them see how important it is for them to help take care of themselves.
How do you get to the next level of that? Because when someone tells me that, I say, great. Which one of you wants to take on the 264 things I have to do today? You know, I agree completely. So what's the next? I mean, because the reality is, I think for a lot of women, and not just women who are single mothers, it's a matter of, you know, I'm responsible for the overwhelming bulk of stuff that has to be done in my family, for my parents, for my kids. So the reality is, I'd love to go to the doctor. I'd love to have that time to go to the doctor or take my health care seriously and put it first, but I don't realistically have the time. How do you overcome that?
Well, I mean, at least when I get asked about that, and I actually bring it up with my patients, it's really about recognizing that there is some shared responsibility. Yes, a woman is the primary caregiver, but she is not the only caregiver. And a lot of the times, women have to negotiate and navigate some others in the family. I mean, I know many of us think we are the ones who have to do everything. But it turns out that that is actually not the case. There are people standing by, but they think you really want to do it all. So, you know, I mean, my husband has always been very supportive and helpful with the children, but sometimes he goes, well, you know, I didn't offer because I thought, you know, you wanted to do that. So I mean, I think that your point is absolutely correct. There are things that the woman has to coordinate, but at some point we've got to begin to let others into the circle and let them share in this loving issue.
I think we have time for probably one or two more questions. Why don't you go ahead?
Hi, I'm Marina Kadeko. I'm Glamour's health editor. For the young woman who's in her 20s and 30s, you were saying has, you know, it looks healthy, feels for the most part healthy. Are there any symptoms that might be early warning signs that her heart is in trouble that you find patients commonly miss?
It's that subtle shortness of breath. Many people would say, I just find that I couldn't, if they are physically active, maybe they're cutting things down a little bit, but also even for women that are not physically active, they actually subconsciously reduce, you know, whether some of the household chores, and so that's, at least in my practice, where I find just having women understand that just because you're experiencing some limitation, because women would immediately attribute it to something else. Oh, you know, I have too much stress at work. Oh, you know, just a lot of stuff going in the family. Oh, you know, I gained weight. But so just teaching them to not push that stuff back, but bring that symptom out to the forefront and talk to someone about it. That's what I find.
Many of the young women I operate on actually run triathlons and yoga, and you know, are active in their lives and their families and their work. And the subtle things that they report, when you really question them, are a sense of fatigue at the end of the day that they didn't have maybe 2 years ago, and also a racing heart, sometimes what we call palpitations or atrial fibrillation. So all of those things should prompt a visit to the primary care physician and cardiologist if necessary.
So it's in the
Yeah, so things that change from baseline.
But the subtlety part of it, I think, is important. It's because it's not always, it doesn't feel like a crisp new thing sometimes. It's more of something that's kind of come along, where all of a sudden the fatigue burden or the ability to do the things you normally do is not quite the same level that it used to be. But I also didn't want to lose sight of the fact that in that younger age group, though, it's risk factors, too, that are a large burden. So not just thinking about the disease itself, but risk factors in that age group. We know that 60% of women ages 20 to 39 have a risk factor that they could actually probably control. And that one risk factor alone can actually double your risk of heart disease. So these are things in that younger age group that I think have the large impact on the future of their heart health.
I have time for one more question, so why don't we bring the mic right over here. Go ahead.
I just wanted to go back to the eclampsia issue during pregnancy. How many women with eclampsia will go on to develop heart disease?
Will go on to develop
Some form of
heart disease. It's actually, the numbers are not very clear now. This large meta-analysis that I talked about showed that a good percentage, and for us, in terms of proportionality, age 2.5 times greater than if they had not had the eclampsia in pregnancy. So it just adds to your risk, and like I said, a lot of this is, again, teasing out what else is going on with that woman and how is this big stress test, in quotes now, triggering some of these vascular abnormalities. And then that again, the research looked at 5 to 15 years. So as you go out beyond that, there may be a cumulative higher risk as well.
And is there anything a patient can do at that point
Yeah.
to either forestall the cardiovascular disease?
Yes, absolutely. And so that's really the big finding from this research is the patient as well as the physician. Because when a physician recognizes that when I have a woman in my practice that suffered from eclampsia, it's not just a thing of the past, but it's something that I need to assess their risk factors now and look at early signs of atherosclerosis, because they will be one of the targets for premature atherosclerosis. And for the patients, it's now also risk factors that they would have thought, okay, I'm just like everybody else, my cholesterol is high, or I have slight high blood pressure. It could be a lot more meaningful to target risk reduction.
I want to say thank you to our panelists.
Thank you.
Dr. Connolly, Dr. Paley, Dr. Cook, Dr. Short, appreciate it. A couple of quick notes before I let you go.
I'm actually, Pat Mitchell is here.
Oh, fantastic.
So Pat Mitchell is here. Thank you so much. We're glad, I mean, you were flying back from the condo, right?
Thank you. I wanted to say how already you've proven the point of today by sharing such critical life-saving information. And Soledad, as always, asking the probing questions that are on everyone's mind. Thank you very much for kicking off this symposium and reminding us again of why we're all here. The Paley Center for Media, partnering with Dr. Hayes and the Mayo Clinic, is so proud to be able to offer these kind of forums where we can hopefully connect those of you whose job and responsibility it is to report the truth, the accurate, helpful, often life-saving information, and the clinicians and the researchers who are in this room who have that information. Chris Gotti at the Mayo Clinic and I started doing these forums. I think 4 years ago we had the very first one, and 200 journalists showed up in Rochester, Minnesota, and spent a long weekend with us explaining why sometimes it's difficult to have the kind of open dialogue between the medical profession, the healthcare professionals, and the people who must and want to provide for their media consumers the information that is so critical for them to have. So I salute the Mayo Clinic's efforts in convening these forums around the country, and in particular on this subject today. And I'm really pleased that you've joined us, and I look forward, along with you, to hearing the rest of the day's information. Thanks very much. Sharon?